Well, thanks guys for all being here today. I know everybody's super busy, and so I'm glad you guys could all make it work because I think I only gave you like a week's notice this time or something. I was really far behind the 8 ball. But anyway, thanks for being here, guys. To start, we'll just introduce everybody. Just your name, how long you've been in emergency medicine, maybe what got you into emergency, or whatever you want to share. So we can start with Matt.
I'm Matthew. I've been in EMS for probably like 4 or 5 years, split 2 to 3 years here, and then about 2 years in the Navy. And what got me into EMS, it's what I liked doing the most in the military. So
Nice.
I've been in emergency medicine. Well, I was an LPN for 7-8 years before. I was house soup of a psych hospital, and then I got into where I am now. That I did an internship with one of our old night charges who recently retired a couple years ago, and I was like in high school, and I fell in love, and I was like, this is where I want to be. And it took me like 15 years, but I made it. So
How long have you been a nurse now?
About 13 years
13.
now. 13,
Dang.
almost 14.
And you've been on nights that whole time?
Whole time.
Dang.
On nights.
That's a
I don't
hardcore
function
night
well
shifter.
before noon. Don't function before noon
Dang.
at all.
That's crazy. Sarah?
I'm Sarah. I'm a paramedic, and I've been a paramedic for 9 years. No, I've been a paramedic for 5 years.
Okay.
In EMS for 9 years. Sorry. And yeah, I just sort of fell into it by accident, but it was a great accident.
And you were the like billing department at the ambulance company before, which I forgot about.
Yes, I was. I started there, and we had to do a ride along as a requirement. And so when I did it, I was like, I have to do this job.
That's awesome.
So before that, I was like, I could never do what you guys do. I don't know how you do your job. And here I am.
Yeah. Jazz?
My name's Shazni. I go by Shaz. I've been an EMT for 2.5 years, and then I switched over to paramedic, and I've been a paramedic for 9 months now.
Brand new.
Brand new, yeah. It's been a ride. The world has been testing me.
What's the biggest difference from EMT to paramedic that you've noticed?
So much more responsibility.
Yeah.
You have to figure out how to get from point A to point B. Now I work full time. Very busy system.
I was about to say,
Yeah.
it's
That
a
it
good place to
tests.
start.
It's very testy. Yeah. There's some sick people, and there's also a lot of traumas. So it's,
Yeah, and short transport times probably.
short transport times. I've been out in West for a little bit, and that has been challenging because it's a little bit longer transport times. It's like 15 minutes instead, which is kind of the sweet spot. It's perfect. You get time to do things and then like see the results of your intervention.
Yeah,
so,
that's true.
yeah.
Nice. Andrew?
Hey guys, I'm Andrew. I have been in emergency medicine specifically. This is the start of my 6th year, but before that did the med school thing and kind of bouncing between different specialties and everything. I think what made me determined to finally land and stay in emergency medicine is I ended up liking a little bit of everything. Through med school you do like 1 month stints in pretty much everything, and thought for a while interventional radiology, then thought anesthesia, thought a bunch of different things, and I think the being available to just the normal person was what really made EM stick out to me. That somebody didn't need a referral to come see me. It was just you could walk in, here's the problem. And I like that. I like the adaptability of it. And
Yeah.
It kind of made you keep your skills up in a lot of different areas rather than, really getting kind of pigeonholed into one thing. And for me personally, that worked out great, and I've loved it ever since.
Yeah. One of our other docs, Lucas, was on a while ago, and he mentioned a similar thing, like regardless of your health insurance status or, wherever you're at in life, you can come see me and I can order pretty much whatever tests we want. We don't have to do insurance prior authorizations. Like there's no barriers to ordering whatever we think you need to work you up. And that is kind of a cool aspect about our jobs that a lot of other physicians don't get the benefit of, depending on what specialty you're in. There's a ton of barriers to seeing a lot of docs.
There is. And it's nice. I mean, all of that you just don't even have to worry about.
Yeah.
You can kind of really get down to the medicine, which I really like a lot, rather than worrying about, the other stuff. And figure out, we're probably a headache for the people on the back end. But,
that's probably true. Well, let's talk about struggles in emergency medicine. This is a topic that comes up a lot. And just pick your guys' brains on like what struggles you've had working in emergency medicine, what challenges you've had. and how you've overcome them, and advice you'd have for new people in your shoes, new ER doctors, new paramedics, new EMTs, new nurses, what advice you'd give somebody that's really struggling when they're starting out. And if anybody has like a story specifically about a struggle, that'd be good to start with. But if anybody has some specific thoughts, go ahead and go for it.
Don't panic. It's not your emergency.
Yeah, that's good.
Just kind of distance yourself without not caring. I think that's a hard balance to strike, because
Totally.
I know there are a lot of docs that I've worked with that have a very stoic demeanor, or seemingly cold in quotes, but they're making really rational decisions, and I don't want somebody that's super emotionally involved with my medical emergency.
Sure.
Even though I think a lot of people see that and they get the wrong idea.
Yeah.
So,
There's definitely a balance there. Like, you want to be kind of above the fray and detached while also making the patient feel like they're being cared for, and because I think that's like the hard thing about our job is, like, you want to be detached so you can take care of them well and not take all this stuff home, but also like make sure the patient knows you're listening and make sure they feel cared for, like they, are an actual human being. But that's a hard balance for sure.
I think my past history working psych was really beneficial. I didn't think my path was going to end up where it did. But it's definitely taken me a lot from that, because I worked on the trauma floor in between my psych and emergency medicine. And it was like a really good transition in between, because you do have to detach, I feel, a lot to move on to the next one, or grandma needs a blanket, and try and, I don't know. I think I'm really good at like turning it off, but then sometimes you have to like turn it back on really fast. So I think that can be a struggle sometimes for new people.
Well, I found like some like way to avoid burnout too is actually like turning on that human side of you temporarily to connect with one specific patient where it's easy or you can relate to them, and like sit down and take a little bit of extra time and bring grandma the blanket, and like if you touch into that human side of yourself just briefly, and then you can kind of shut it down and go back to like doing all the crazy stuff you've got to deal with, because we can't do that on every single patient, or I feel like you bring all of that home with you and you just can't. And so I think but taking some time to do it intentionally throughout the day, I think actually helps you not burn out, because you're like, hey, I actually connected with other human beings today, and that's why I initially got into this job. And yeah, that's a good point.
I also think it's nice when we have nice patients. And like, I take the time to thank my patients for being nice to us too, because I feel like that's, my first year down where I am now, and the level one is just, it was during COVID, so I didn't have anything except for either really, really sick or nothing balls. And so, but we didn't have sedations, we didn't have anything. So off orientation, it was like, good luck. But we have such a great team there that I think that team atmosphere is so important in any kind of medicine, but especially emergency medicine, because there are so many different specialties that get to work together to put the puzzle pieces together.
Yeah.
I think it brings up a good point too, and one that it was hard for me to realize, like at the beginning, like right when you get out of training or like whatever it be, you graduate, you feel like you should know it all, and very much so you don't know it all, and you're not supposed to, right? Like basically when you graduate, you've been deemed safe enough to like start doing the job. And so I think that helps, especially when you're new and you're getting out, is don't worry that you need to know everything, and realize exactly like what you had brought up. I mean, this is a team sport in almost everything that we're doing. And when you keep that in mind, I think you give yourself a little bit of grace. Now you're still doing the best job that you can, and you realize, hey, I don't know this. But I think it also gives you a little bit more comfort in saying, I have reached kind of the end of what I know how to do, so now I'm going to reach out to someone else to help. And that in the end is going to give good care. So that's helped a lot with like when you're a new person, getting your feet under you and getting things figured out. And the best doctors I've seen, and really the best nurses and EMTs and paramedics, they're the ones that have done the job for a while, and they're the first ones that'll tell you, hey, I'll do this, and I'm a little uncomfortable with this part, so I'm going to reach out to my colleague for this. And you just know you're getting good care, because no one's trying to like put it all on their shoulders.
Yeah. So. Well, it's a good point, I think, about, especially when you're new, if you have like that false confidence, or if you're arrogant, you don't realize when you've hit the limit of what you're able to do, and so you don't reach out for further support when maybe you should. And that can be a dangerous place to get to. So I think that's great advice, to realize we all have our limits in our knowledge. Nobody knows everything, so you need to be able to find those resources or talk to that specialist when you're at that limit. And it can be a hard point to figure out, I think. that was something I found as a PA, is like, where's that limit of when do I need to get a physician involved? And it took a little while before you're like, okay, this patient I'm very comfortable seeing, discharging without getting a physician involved, but where's that point where I need to get a physician involved? And it takes a while to figure out where that line is, for sure.
It does. I think, at least for me, I sort of erred on the side of like consulting more or asking more help. And then you sort of realize, all right, I can kind of like back it down a little bit. Mm-hmm. Some people go the other way. They're like, oh man, I made a mistake. Now I'm going to ask more. But I think don't be afraid to ask more at the beginning. And then you'll sort of fall in naturally to, that area where you're, I can handle this, right? I've heard or seen all the stuff that has to do with this problem or whatever.
Right.
So, yeah.
That's probably a huge hurdle that I had to jump over trying to be confident as like a new paramedic. I feel like there's so many things I don't know. And I'm constantly like coming up with new meds that I have to give that I've never given before. I don't know if there's going to be an adverse reaction. I don't know what's going to happen. And like, I don't have anybody to consult.
Yeah.
Like I can call a friend, but that makes me look incompetent to my patient. And so that's been a really hard place, because you go to the hospital and you're like, drop off your patient. And you're like, hey, I don't know if I did the right thing. Can you give me some advice? And I think that being willing to say, I don't know if I messed up or not, has been the biggest like contributor to my practice recently, is just being willing to say, I don't know. And I would love some advice on next time I interact with a patient that looks like this. And
that is a really scary thing about being a new paramedic, is you're familiar with all these drugs, like you've studied the heck out of like 30 drugs that you know super, super well, but like giving them for the first time, you're like, is this the right circumstance? Is this the right patient? Should I have done nothing? Or am I going to be in trouble because I didn't do something? Like, it's a really hard balance to find when you're a brand new paramedic.
Yep.
And some of the meds you don't give except once every, like once a year, twice a year, but you want to be giving them when those circumstances are there. Cause they're usually for something pretty life threatening, some dysrhythmia or something, and like they're indicated. So especially when you have a long transport time up in the mountains.
Yeah. Yeah.
And those people wait. They wait a long time to call 911.
Yes.
I feel like we've all worked with both types of people, and for us on the back end, we all like the people that want to ask for help, as opposed to the super confident person that very overly confident, and then the patient's probably like, oh, this is great, I'll take that ketamine, that sounds great. And then on the back end, we're like, thank you for asking for help. Like, so at least on our end, it's better.
Oh yeah.
It's hard, I think, too, when you're new, because the paramedic protocols are often very different than how we practice, even with certain medications in the ER. So, like when the paramedics were giving ketamine for pain, it threw everybody off in the ER, because we're like, this patient's like totally snowed. And you're like, I gave the right dose. It was totally indicated. I'm so sorry. Now they can't answer any questions. But like, it was totally appropriate. But I remember when it was first introduced, I got yelled at by some docs in handoff. Like, you completely snowed this patient. I'm like, I gave the right dose. It was for pain. Like, it's indicated. Like, here's where it's in our protocols. I'm so sorry they can't talk to you now. I thought it was the best thing for them. But yeah, I mean, some of the docs aren't very familiar with like how you can give meds in the field, because it is different a lot of times than how we use ketamine in the ER. But yeah, you kind of have to let that roll off of you, especially if it's a doc that's not familiar and they're not familiar with the EMS system. Mm-hmm. But
I think that's a good point, because there is a lot of people that aren't familiar, and so it's going to be easy for you to feel like, oh man, I really messed up. When in reality, all those protocols have been vetted by everyone to go out there. So a lot of it is just on the ED side of not realizing what you guys are doing. So trust the protocols, trust your medical director that they've kind of gone through those and done those things the best you can. And if you get feedback that's less than ideal, pass it along to your medical director. But just having confidence in those protocols, I think, is important. I did a EMS fellowship, so an additional year doing medical direction for EMS, and I thought I knew a decent amount about EMS, but really until I delved in and really got to the day-to-day stuff, I mean, it's way different, right, than the emergency department. And so I think having that understanding changes the way that you approach crews when they come in. And I wish that all of emergency medicine physicians and nurses and everybody that works in the emergency department had a little more time to work out in the field, because it really is, it's so challenging. I mean, you are literally the first line of filtering of whatever this complaint is, right? And so, I mean, yeah, it's easy to question on the backside of, oh, okay, now we know it's this problem because the wife showed up and told us more info. But I mean, you guys are the first ones there, getting that stuff started. And I think that a lot of grace in that realm is important, because you're just trying to do the best you can while you're like rolling down the road. So, but I think realizing that a lot of doctors don't have that experience, and don't let it get to you. You're doing the right stuff when you're following the protocols. So.
Yeah. And they're dealing with all the operational stuff too, like how we're getting the patient out to the ambulance, like on top of dealing with the medicine. Like, you have a lot of stuff going on that call that you're thinking about. And then you've got to figure out, well, do I need to treat the patient for something after we've carried them out of their house? And yeah, it's a lot.
Yeah, I'm really glad that you acknowledge that, because I can tell which doctors don't know what we do.
Right.
I'm like, listen, I promise this is what we're supposed to do.
Right.
There's a reason I did this. If you
Right.
want to talk to me about it, I am happy to do that.
Right.
But yeah.
The crappy thing too is you'll have like a reputation in the ER, like as a paramedic, right? You'll bring somebody in and they'll either be like, oh, this is a great paramedic, I hope this is like a well packaged, awesome like patient, but then it'll be like a crazy call. There's so many things going on, and you as the good paramedic cannot be everywhere at once. So although like the C-collar's done right, the like spider straps are put on correctly, the medication was given wonderfully, but I don't have very good EKG tracings, like you can't be everywhere. Like you
Right.
can't do all of the things. You can't have two good IVs. I can't be on the same side at the same time, and so you get like some crap from the ER when you have just a couple things wrong, when like overall I think I did a pretty good job.
You can't clone yourself?
Right.
Come on.
Yeah.
I can see. I mean, it would affect you so bad as a new provider, right? When you're like, the book has everything so clearly laid out and like clean, and real life is just not clean, right? And as much as we wish it was. And so I think giving yourself grace, and as you have more time in it, you realize I did do a good job, even though everything's a little bit fumbled because of this or that. But when you're new, don't let that discourage you from doing. You're doing a good job. You'll just learn eventually like what it defines success really on a patient that you brought in. You've gotten them there. Like most of the time they're breathing, sometimes they're not, and you still did the right thing because you brought them in. So I think that'll help a lot when you're new starting. I know it did for me.
But all of those like difficulties or failures, they help you, because then you know that for next time.
Yeah.
Like, I have a million. I have a million reasons. Like, I'll go back and I'll be like, oh, this happened on a AFib call, so I'm going to do something else next time. And it works. So I'm like, well,
Yeah.
somebody's going to be helped by this.
There's nothing that teaches better than experience, like just call after call, because eventually like you've seen
100%.
similar stuff, and if you've seen it, but when you're 9 months in, like you just haven't seen a lot of it by yourself or even at all, and so you're trying to deal with it. But after you've like seen a similar patient or a similar dysrhythmia, like once you've done it a few times and you're like, okay, this is what I did last time and it worked out great, or this didn't work out great last time, like there's nothing that teaches better than just running call after call.
Yeah. Ironically, I had 2 third-degree blocks back to back.
Oh, dang.
Yeah, I gave atropine on both, and everybody was like, "Oh, you shouldn't give atropine. That never works." All the older medics were like, "No, we shouldn't." And I was like, "I'm gonna do it." And it worked both times.
I'm
So
trusting.
it's wild.
Yeah.
Yeah. It's just crazy. And having those 2 back to back. I don't think I would have done atropine the second time if I had that separate. But having those experiences was really cool, and like just. It taught me a lot. Just that small little,
Yeah, that's pretty cool. 3rd-degree blocks you don't see very often.
No.
Especially when they're symptomatic enough to call 911. Sometimes we'll find them incidentally,
Yeah.
but they've probably been in it for a long time.
Yeah.
But if they're calling 911, oh dang.
Yeah.
Oh, that's even worse.
I did the atropine, and then right after it was like massive tombstones.
Oh,
and I was
dang.
like,
The old 1-2
I
punch.
found
yeah.
it.
Dang.
I was like, that's the problem.
That's probably why you have an AV block.
yeah.
That's pretty cool.
I feel like that, I know it's kind of a dirty word in like a peer-reviewed scientific community, but the art of emergency medicine, I feel like that kind of plays into it, because it's hard to describe things like that. You don't have like a really scientific, clear-cut, especially in the field where it's just like, yeah, this is I'm superstitious because, now I am at least.
I'll pull crash cards out in front of rooms just to be like, we'll leave it here.
Exactly. This
I
is
don't
word
need
off
it.
stuff.
Why not? Yeah.
Yeah, it's definitely an art. I had a doc when I was a brand new paramedic. I was working with a brand new paramedic. We brought in a patient that had passed out, and the doc was like, well, did he almost pass out or did he fully pass out? And like, he's being really like aggressive towards my partner who was trying to give report. And my partner's like sweating. He's like, I think he fully passed out. And the doc, I'll never forget, because the doc was like, well, did he fully pass out or did he not? This is an exact science we're practicing. And I was like, no, it's not. This is not an exact science. This is the very definition of not an exact science. Like, everybody reacts differently to things. No patient's the same. I mean, there's a lot of like standards, but this is not an exact science. The same thing doesn't always work every time. And I just think that was kind of funny, because it's just so not true.
It's not, especially as an EMT, because I tell people, because obviously nurses have criteria, it's very algorithmic, so do providers, but when a charge nurse is like, well, they're outside of criteria, and I'm like, I'm going to be honest, this person makes me extremely uncomfortable, and that's all I got for you.
Yeah.
And then turns out, like, something pops off.
You got to trust that gestalt.
Oh, exactly.
Mm-hmm.
And it's just hard to, I think it's hard to explain, especially the kind of the culture of field to nurse.
Yeah.
Trying to get past that barrier of like, okay, I know it's not on the algorithm, but this person's sweating in a weird way and I don't like it.
Yeah.
Yeah.
And
Like, something's just off. I don't know what it is
Exactly.
yet, but
And I'm
something's
sure,
weird about it.
Everyone can attest to that. They've just had that kind of experience where
Sweaty
There's spidey
patients should
sense.
make you nervous.
always
Yes.
slick, pale, sweaty.
No. I had a paramedic named Matt years ago told me, he's like, when patients are sweating, I start sweating. And I was like, oh, that's a good one. They should not be sweating.
Especially when it's 70 degrees in the
Yeah. I had a patient that came into intake after a car accident that was sweating. And I was like, oh, man, this needs to be limited at the very least. I don't know, like, what's going on. But I was like, and it turns out it had just rained. And they had just rained on him. I was like, well, they're a limited trauma now.
Perfect.
I didn't realize it was raining outside, because they told me they were sweating too. So I was like, well, but maybe not that much.
That's kind of funny.
Like, you shouldn't be sweating after a car accident. There's something wrong with that picture.
Yeah.
Like you failed your stress test or
Something's
something, and now
wrong.
you're having a heart attack. What qualities have you guys had to develop working in emergency medicine? Is there like anything specific you can think of that's helped you navigate it and avoid burnout and do this job?
I think one skill that I kind of wasn't expecting to have is just how much multitasking sometimes has to happen. And I've heard people say that it's not really like multitasking. It's mostly just rapidly shifting between focus. And I think that's probably a good way to describe it. And I think for me, at least, and other people are just naturally good at that, but for me, that was a challenge. And it even today still can be. So I think one of the skills that I've been really trying to develop to fix that is just trying to be in the chaotic realm that we work in, trying to be as organized as I can in my mind. And so, like, for an example, in the ED, at least, if I'm working an actual shift, we have a track board, right, where we'll see all the patients on there. And so, like, getting into the habit of just reviewing that track board every second I can have. So, okay, so where are we at with this patient? Where are we at with this patient? And keeping myself organized to then be able to task switch so quickly and not just lose it. Mm-hmm. I mean, I remember, so one example, when I had just started, I think this was my first year in emergency medicine, I was working, I was in Indianapolis working at one of the Trauma One centers down there, and I had like 12 or 13 patients on my board, which was like right there at the edge of what I could juggle. And I remember I was going to go order a medicine for this one patient, and then I got interrupted because another patient came in and had some issue. And it took me some time to realize, oh man, I didn't put in that med. And then the nurses came over and said, hey, I thought you were going to put in that med. Even today, that sometimes will happen. But what I try to do is like reviewing that track board just to be able to keep yourself as organized as possible. And I think that was a skill that I didn't expect. I assume it probably can translate into, pre-hospital world too, but just trying to find ways to checklist yourself and repeatedly do that to keep on track. I think that was a skill that I've been trying to work on.
And figuring out like which tasks. Because I mean, at any given time when you've got 12 patients, there's a lot of tasks that need to be done, and you're like, what's the priority I need to do them in? Well, that one just came in by ambulance, probably need to go do that as number one priority. They have no orders in, no providers laid eyes on them. So I'm going to get up from my chair, whatever I'm doing, go see the ambulance first. That should be the higher priority. And then, okay, this patient's resulted. We need to get them discharged or admitted or whatever needs to happen. This one needs Zofran. I mean, it's hard to balance all those tasks when there's a constant stream of them and figuring out what the priority is too. Mm-hmm. That was a big jump from paramedic, was like the multitasking, but really the, one task at a time, doing triage, a whole bunch of them.
Thing, yeah, for sure.
Because that's what was kind of nice about being on the ambulance, is you have like one patient I can focus on just doing the best thing for this patient, and like I've got a good half hour with them, and I can figure out their whole story. And like in the ER, we just don't have that kind of time, and we have so many other patients simultaneously. You just can't spend a half hour with one of them. But that was a big difference for sure.
When I'm training like new nurses, especially to the ED, or I guess new grads now that they just started to, towards like the end of their orientation, I'll do what I like to call controlled drowning, if possible, where I'm here as your preceptor, but I want you to try and handle this cluster on your own. Use your resources, use your providers, use your techs, use your people that have been here and know their gut and, can help. But I'm here, so you're not actually drowning.
Right.
But I want you to feel this, because that's part of it, I think. And if you can maintain your cool, and I chart by like sticky notes. I have packets of sticky notes in my pockets at all times, so that way I don't forget something, even if it's something silly, or I'm like, oh shoot, I forgot to go turn off that person's light. Let me go do that. Good thing I have my sticky notes,
Well, that allows you to not like have it all up in your head though, so you can focus on whatever you're doing at the time, and like you're offloading that task. I think that's a great technique.
You really only have like a certain amount of bandwidth, right? At least I've noticed. And like whatever you can do to offload that off of your like table in your mind just makes you a lot more flexible to handle like an additional task that comes in. And that's definitely a skill that takes a lot of practice. Mm-hmm. But I think that's a great point, bringing up something to try and offload that mental like stage and give yourself more room.
I think that's great to let them feel like they're drowning with a backup, though, because I think you kind of have to reach that point, because you're going to get there. So it's good to get there when you have a backup, because I remember when I was a brand new PA working in the fast track part of the ER. So it's just me. There's no other providers. And they started loading me up, and I had like 6 patients simultaneously. And I was like, oh my gosh, I can't hit like 6 patients at the same time, and they're all just super low acuity. Like they don't even have that much stuff ordered. Like there's not that much that needs to be done, but I was still like totally overwhelmed. And that's like the only time in my life where I was like, I feel like I might have a panic attack. Like I have so much stuff. I haven't seen this one, haven't seen that one, but like they all have orders in. It was, a lot of it's in my head. And then I was like able to take some deep breaths and be like, okay, let's just do one thing at a time. I can't go see all 6 of them at the same time. Just see one patient, and you just start knocking out the tasks that need to be done in their care, and then you're okay. But when you're looking at the whole picture, it can be easy to be overwhelming.